be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I'll be brave if you're brave. I'll be brave, but only if you're brave.
Welcome to those of you who are able to join us live this evening, and to those of you who will come back and watch post-live. We're happy to have you. I'm Danielle Hicks, Chief Patient Officer here at GoTo Foundation for Lung Cancer, joined by my co-moderator, who needs no introduction, Bonnie Adario, co-founder and chair of GoTo Foundation for Lung Cancer. For those of you who aren't familiar with our Living Room program, it's a support and education series created specifically with patients and caregivers in mind, with the aim of facilitating educational talks from key opinion leaders. And I'm excited for you guys to meet our panel of key opinion leaders here tonight. We've got three folks on the line. We've got Jamie Studts, who's a PhD and professor at the University of Colorado School of Medicine. He's the scientific director, behavior oncology, University of Colorado Cancer Center. Stephen Huff, who's a survivor and advocate, and Jim Pantelas, who is a survivor and advocate. You may recognize some of these faces as they are very active in our community. As I said, tonight we're going to be talking about stigma. And if you noticed in the title, we actually asked the question, can you feel it? And I'd be willing to guess that most of those out there who have been diagnosed with lung cancer, as well as their caregivers and family and friends, have felt it and would say yes to that question. So we're excited to have this conversation. Before we get started, I always like to ask our panelists to give us a little self-introduction, tell us who they are, and why lung cancer matters to them. So I'm going to start with you, Jamie, and then we'll move over to our patients on the panel.
Thank you. Happy to share a bit about what brought me to this community. And I worked in Kentucky for the first 20 years of my career, and I gained an appreciation for the burden of lung cancer in our Kentucky communities, in rural areas. And I learned about the importance of stigma and from people, and began to explore it a little bit more scientifically in my own research, and then took on a more advocate role, I would say, in terms of addressing lung cancer stigma from a societal perspective, and thinking about ways that our society could change to embrace those individuals at risk for lung cancer, as well as those who've been affected by lung cancer, in the same way we embrace other communities who experience cancer. And so that is kind of what brought me here. And I'm just so excited to be here and part of this living room. I don't know if you really appreciate how important it feels and how wonderful it feels to be invited as a scientist and researcher to participate in the living room. So thank you.
Thank you, Jamie. We're so happy to have you. Stephen, you want to tell us who you are and give us your story and background?
Of course. Thank you so much for having me on tonight. It really is a pleasure to be here. And so a little bit about myself. My name's Stephen Huff. I live in the Middle Tennessee area, and I am 32 years old. I was touched by stage 4 lung cancer at the age of 29. And it, much like everyone else, it was a complete shock. And so when I received a diagnosis at the age of 29, I wasn't sure what to make of it. And to learn that it was lung cancer on top of that was even more shocking. The only thing I had ever known about lung cancer was that it was related to smoking. And so here I am. I was diagnosed stage 4, and I am a 3.5-year survivor, I guess you could say. And I like to talk about my life after my diagnosis, because I feel like that is something that, my diagnosis has really in kind of a strange way, it's been a gift for me because I appreciate life way more now than I ever did before I was diagnosed. And so I'm happy to say that after my diagnosis, or since my diagnosis, I've gotten married, I've bought a house, I work full-time as a teacher, and in January, my wife and I welcomed our first bundle of joy. So we have a family now, and life is great. I am considered stable at this point, which is truly a blessing in more than one way. So I'm just glad to be here. I'm very excited to talk about stigma as it relates to lung cancer, specifically with young lung cancer patients like myself. So I'm very excited about tonight. Thank you for having me.
Thanks, Stephen. We're happy to have you. Jim, what's your story?
I'm a 15-year survivor of non-small cell lung cancer. I'm the son of a father who died from small cell lung cancer back in 1980. My personal experience was kind of complicated because my wife was 6.5 months pregnant the day that I got diagnosed. So my daughter just turned 15. She has 2 younger siblings. Grace and Lita are now 12 and 11. And I've been through surgery, chemo, and radiation, and I have been dancing with Ned, no evidence of disease, for 15 years now. I have been working with Jamie for the last year and a half, on a project for the National Lung Cancer Roundtable, where we've been having fun trying to figure out how to deal with the issues of stigma. So when Jamie tells you that he's kind of interested, he's really, really invested in this. The hours that we've put into this have been enormous, and he's led the subcommittee all the way. So I'm really honored to be here. Thank you, Bonnie.
One of the important starting points is really kind of identifying what is stigma. And Jamie, I'll start with you. Can you talk a little bit about what stigma is, and the difference maybe between social stigma and self-perceived stigma?
Sure. So fundamentally, when I think of stigma and talking about it in the community, and is that it's an othering. It's a systematic way of behaving and thinking that separates people. It puts people apart. And it puts them in a lower category where people sometimes feel superior to them, and so it creates a distance between people as opposed to bringing people together and uniting them in different ways. And that's sort of the societal perspective. And you alluded to that there's many tiers of this and different aspects of it. How society thinks about individuals diagnosed with lung cancer or at high risk for lung cancer is one. But there is a subtle, insidious, and similarly brutal part of it, and that's the self-blame or self-stigma that some people experience, not everyone experiences, but it can be very damaging the same in terms of in terms of our ability to engage some of the really tremendous innovations that are happening in the entire lung cancer prevention and control and care arena, and it's just toxic and it must go.
Stephen or Jim, do you guys have anything to add around the just general what is stigma conversation?
I would just add that in many ways, the stigma that attaches lung cancer to tobacco use has been an engineered stigma, in my opinion. There have been marketing decisions made over the years to pit non-smoking friends against their smoking friends to convince them to quit. And you don't do that without unintended consequences. I won't say that the stigma is purposeful, but I think it's an unintended consequence of the way that we've dealt with tobacco for the last 50 years. And part of dealing with stigma is understanding that there is a relationship between tobacco and a lot of diseases. We've got 600,000 heart patient deaths every year in this country. And the biggest or single most causal factor in heart conditions that is possibly dealt with is tobacco. But heart disease doesn't suffer from the same stigma as lung cancer does. And it's because there was an outright effort to make or to attach tobacco to lung cancer.
What we're talking about right now is why stigma sort of developed around lung cancer. And I think tobacco is definitely one of them. Is there anything else that sort of ties in with that, in your opinion? And this is open for anyone.
You look at people with diabetes, AIDS, heart disease, lung cancer. We could go. People are more comfortable if they can blame those diseases on something specific, so then they don't have to worry about either getting it themselves or defending themselves for being a smoker or an overeater or any of those things. It's kind of like it's about the blame and the shame. You have to blame people and then you have to shame them. So they retreat into a corner. And we need people to come out of the corners together, smokers, never smokers, non-smokers, whatever. We to come out like they did with AIDS and diabetes and, even mental health. I love it that we're starting to see, mental health being something that we need to take care of. And it's always been something we've needed to take care of. But we have to take all of those things and come out of the shadows and say, come on, world, let's fix all of this. Let's not just pick and choose what we decide, who we decide to blame and who we decide to shame. I had a lady one time. This was early on when we first started this foundation. And what she told me just made me cry, because she said, I told people I had breast cancer because I didn't want to tell them I had lung cancer.
Whenever something terrible happens to someone, we all search for answers, and we all subconsciously and secretly attempt to maybe try to protect ourselves or protect those around us. And we do this by creating this halo of, we convince ourselves that, this person or this loved one must have done something to cause this. And I certainly don't want this to happen to me. And so the instinctual reaction is, you smoked, I didn't, now I'm safe. And that gives me that feeling, that safety net, that halo. And I know that as a young lung cancer patient myself, even the people that know me the best, people that know, my history in athletics and exercise and fitness, it's still always the first question. Even people that know me better than, my best friends, they say, did you smoke? And I think that it just further validates this notion that prevention is the only thing that we have ever known about lung cancer. And we're taught from a young age that, nicotine is this highly addictive substance, but we're not taught that, healthy lungs can develop tumors.
I don't know if you remember this or not, Bonnie, but several years ago, the line was that if you quit smoking, your lungs will heal themselves. The cilia within the lungs will regenerate within 5 years. So if you quit smoking for 5 years, your lungs will have repaired themselves to those of never smokers. Part of what we're having to deal with is that kind of urban wisdom that isn't. Part of what we're having to deal with is is people that quit smoking a long time ago who think that they can't get lung cancer now, so they don't need to get screened, because they haven't smoked in 10 years. And we're having to deal with a misconception that lung cancer feels like it's a lot quicker than it really is. When I was diagnosed, my oncologist told me that the lung cancer that I have probably started 20, 25 years ago. And when they actually got some asbestos out of my lungs, I can tell you when I worked with asbestos, it was in my late teens and early 20s. And I was diagnosed at 52. So it's almost an issue of changing the conversation and at least making it more transparent and more honest. The reality is that if you smoked, you have increased the likelihood of getting lung cancer, and that's just a fact. And if you haven't smoked, you can still get lung cancer, and that quitting is still a really good thing. But let's not try and tie them together weirdly.
I
Go
agree.
ahead, Jamie.
Yeah, I'd like to jump in here because I think there's an additional theme and additional point that I'd like to make. And I want to give credit to Jill Feldman, who introduced me to this TED Talk, because I think it captures one of the things that we're battling in here. And that's the challenge of the simple story. The essential piece of this is that our entire society reduces lung cancer to tobacco. And if that's the only story that people understand, we are at a huge disadvantage because there are multiple risk factors for lung cancer. There are multiple strategies to cope with lung cancer, to treat lung cancer. There's a much broader story out there that our society does not understand. And part of that is what I think of as Estigma's younger sibling, nihilism and fatalism. Because the other part of the story is a very poor prognosis, and which leads us into the greatness of all these innovations that we have in terms of treatment and stratification and better targeted therapies. This is an opportunity to infuse hope and realistic hope and optimism throughout our society, and to change the way our culture thinks about our community that is far more complex than what we learned in grade school. And I will go a little bit further than Jim did, which strikes me as hilarious, in saying that they not only have said, he said that stigma has been used accidentally. I think it's been used purposefully. And in terms of my colleagues, my tobacco control colleagues, and I'm one of them. And when I started my career, I know I did things that were stigmatizing, and it's a learning process, and we can all do better individually as a society. But we do have to understand, like Stephen was saying, the consequences of some of these messages, and understand that they do have toxicities in themselves that have created the toxicity that is lung cancer stigma, and it's completely generated. There's absolutely no reason for this stigma to exist naturally. It is concocted, engineered, I think, is what Jim said.
Smoking was considered a driver of lung cancer for decades. We have new drivers now for lung cancer: EGFR, ALK, ROS1, RET, MET. I can go on and on. So what we have here is multiple different drivers that are creating certain people to have lung cancer. So if somebody asks you if you smoked, you can say, well, no, actually smoking wasn't the driver of my cancer. The EGFR mutation was the driver of my cancer.
I want to go back just for 1 second because I think this is an important point. What people aren't looking at is never smoking lung cancer is still the 5th largest cancer killer. 5, right? And I thought, wow, if that doesn't kind of speak to smoking, or not being a safety net, I don't know what really does. So that's one point I want to make. And then I kind of want to end with how we flip this on its head and what do we do about stigma now. But before we get there, I do want to talk about the impact that this stigma that we all realize to be a very real thing, what impacts has it had on lung cancer and the movement sort of forward in the last half a century?
Some of the things that I see as an advocate working in what I think are some of the country's best research institutions, and meeting and talking to oncologists that will tell you, that have told me to my face, if a patient says that they never smoked and they have lung cancer, I know they're lying. Or that work in institutions that have policies that say that they won't do a resection or a lobectomy on a patient that is a current smoker until they've quit for 30 days. That's a denial of care, and it goes against NCCN guidelines. And I know that an awful lot of people, I've met an awful lot of people in the medical profession that say, "Oh, that never happens." And I can tell you as a patient advocate that it does happen, and it continues to happen. So the fact that clinicians are thinking that this was preventable and that it's the patient's fault and that this is a good opportunity to get them to quit smoking is that darling elephant in the room. Part of the problem it also resides within our community because we define ourselves as smokers or non-smokers, and part of what we've come up with in the stigma subcommittee at National Lung Cancer Roundtable is in trying to eliminate the term smoker. We just distance ourselves in our own community by defining whether or not we smoked or didn't smoke. For me, I stayed out of this community for the first 5 years because most of the people in our lung cancer community who are activists are the people that are really pissed off. And they're mostly pissed off because they never smoked. And as a former smoker, I felt ostracized from my own community.
We have and smoking can be a driver of lung cancer, but so are the markers that we have. Patients get very excited if they have an EGFR or an ALK or a RET or a MET or something like that. It's like, oh, wow, I have a chance. But you have as big of a chance as that smoker has having that other driver. And then you can go to radon and you can go to, all the stuff in the walls and that are causing cancer.
Bonnie, that's the science that this entire stigma has eliminated in the last 50 years, is the study of the combined risk factors. The latest combined risk factor that you can find for asbestos and smoking is from 1965. Nobody's done a combined risk factor on asbestos, radon, and smoking, or living in a smog-filled city and having radon, and we've just kind of killed that because we took the shortcut. We said it all is because of smoking.
I mean, can they determine definitively if someone has a smoking history that their lung cancer was caused by smoking, as opposed to
No.
they may? right? So they, I mean, they may have gotten it anyway.
Yeah, when you ask a newly diagnosed lung cancer patient if they smoked, I think it does hurt both parties, and what I mean by both parties is the smokers and non-smokers, and because if you smoked, it reinforces the guilt. If you never smoked or had quit for many years, you might feel some sort of burden for having nothing to blame. And so, correct me if I'm wrong, Jamie, I want to say somewhere between 70 and 80% of newly diagnosed lung cancer patients are patients that quit for an extended amount of time or never smoked. And so this public message of don't smoke, how does that fall on people that quit for 10 years or never smoked? And the answer is it doesn't do anything. And then, to piggyback on that, I think that even within the lung cancer community itself, there is a secondary or substigma of the, I have smokers or I have non-smokers lung cancer versus smokers lung cancer. And so that's something that that we need to address as patients, advocates, as ourselves.
Yeah, I want to, Stephen, it is about 33% of individuals who are diagnosed with lung cancer are smoking are using cigarettes or other tobacco at the time of diagnosis. But you're right, there's no definitive way of determining whether smoking history played a role in the cancer. And at the time of diagnosis, the only reason to talk about smoking for those individuals who is to explore whether they're interested in quitting in a compassionate, empathic way. There are benefits to quitting at the time of diagnosis, but it's not for everyone. And the far more important point to achieve optimal patient care delivery and outcomes is to embrace this individual and help them through the process of receiving the best care through biomarkers and targeted treatments and whatever is evidence-based at that point. But stigma intrudes. It interferes in clinicians. It interferes with our own ability to make decisions about going to follow something up and wanting to be stigmatized and not wanting to be stigmatized by a primary care clinician or a front office person or wherever it comes from. Those are all disincentives, harmful barriers to our community being embraced and treated like any other individual. It's just hard to think. I just keep coming back to the complexity issue. And it's just, our story is complex. Our community story is much more complex than they know. And to the extent that we're successful at helping society understand lung cancer in a much more complicated way, I think is going to parallel our success in reducing and eliminating stigma. Because I'm all for dividing and different types of tumors because it guides to treatment, but we can't afford to be divided in our community. And to the extent that inside our community, if we talk about and differentiate too much, we divide ourselves and we're not going to be as effective at moving forward. And finding ways to have compassion and empathy and share support for anyone in the community and helping them learn. I think, Stephen, you mentioned that, most people do identify that division very early on, and takes a while to understand why the bigger community has perhaps prefers not to necessarily identify and divide that way because of the toxicity that has within our group.
Smoking, non-smoking, genetic markers, radon, asbestos, whatever. I don't know why people are so fired up about finding out what causes a disease and not spending enough time figuring out how to fix the disease. You can go back to diabetes. You can go back to AIDS. You can go back to, even heart disease, because honestly, it's not highly stigmatized. But people do walk away thinking, well, that person ate too much cheese and they just didn't have a good diet. And because people need to hear something that makes them feel like they're never going to get it.
But it's stigmatized because nobody survives it. Not because they're smokers, because most
Right.
people in Kenya can't afford tobacco products. But it's not survivable. And I think that our stigma is in part because we haven't been able to spread the words of hope that Jamie always goes back to. And that's
Right,
that,
exactly.
in 1991, we had our first standard of care developed for lung cancer.
Right.
Now we have a couple dozen. I mean, I sit on IRBs and I watch these trials come through, and there are some incredible trials going on for lung cancer, but there's also incredible progress being made in dealing with lung cancer, and that hasn't caught up to either the medical community as a whole or society.
You don't have to tell a smoker that smoking's not good for them. They know, right? And there's the addictive, the factoring in the massive addiction that these patients have is a whole other conversation around a living room. But you don't have to tell them, yet you still do, right? And I think when we look at how it has impacted things from as early on as screening, screening's been approved in this country for several years now, yet our screening rates are still lingering around 4% of the 10 million people currently qualified for screening. Right. And why is that? And I have to believe that stigma plays a huge role in these folks not wanting to go in, admit they smoked, then have to sit down because of the way the protocols, work, and have conversations, if they're current smokers anyway, about quitting smoking just to get into the CT scanner. Right. It feels like again. And I think screening is just one of the many places. I heard, Jim, I think it was you that mentioned, physicians sort of denying care or access to it because, well, you smoked, you're 70 years old and you should just go home and get your affairs in order. And bear with me because I'm coming full circle to where, it's really impeding progress still because amazing things are happening today and people don't know about it. Mom, I think you want to say something.
Here's what I believe. There is so much good going on, in lung cancer right now. And we've waited. I mean, in the last couple of days, we've waited 40 years for a drug for KRAS. 25% of lung cancer patients have the KRAS marker. This is such good news. We have to change our communication to being really positive about all the good things that are going on, because even to Jim's point about the mortality rate and, smoking, blah, 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 whatever, we're changing that. It's happening in real time.
Yes.
People are surviving longer and longer and longer. Stage 4 patients are surviving longer because we're actually doing surgery on stage 4 patients and chronically managing. We have to start being positive and excited about that. And once the community starts to hear that, they'll stop talking about smoking and whatever, and they'll start feeling like, wow, now I don't have to worry about that disease because if I get it, there's a solution.
So Jamie, societal changes. Let's start there.
Well, I think this, building on what Bonnie just said, is through this National Lung Cancer Roundtable Stigma Initiative, we've identified several themes that we would like to embed into our communications nationally and winnow that down all the way down to local communications. And those three things are urgency. And Bonnie, citing dates and times and things like this is just just a poignant example of how important it is to leverage that enthusiasm, that innovation that's happening now. And the entire oncology community is recognizing that lung cancer research and practice are leading oncology right now. I joke a little bit, say we're after decades of being completely ignored, we're finally the cool kids, and everyone in fellowship wants to be a thoracic oncologist because they have so many tools and there is so much optimism, and so we have to harness that in ways that can really change our societal perspective. So one of the theme is urgency. The time is now, and this is our best opportunity that we've ever had. We've got screening, we've got diagnosis, we've got treatment, we've got palliative care innovations. It's all there. Reasons to be optimistic. The second one is support and compassion and empathy for our community, instilling that helps society understand that we're no different than anybody else that's diagnosed or facing cancer, and it's okay to engage us in that same way. You don't have to ask us if we smoked or not. If we do our jobs well, we can educate society to understand this. Is how about if they ask, "Oh, did you have that KRAS marker, or are you one of those Ross wonders?" How would that feel, as opposed to it's a communication that, wow, the society really understands me. But even better than that, what if they just said, "How are you? Is there anything I can do?" Why don't we get that response? Everybody else gets that response when they share a diagnosis, but instead we get, "Did you smoke?"
I can't tell you how many people I have had ask me, "Oh, are you taking that drug that I saw on TV? What's it called?" And it's usually or typically it's an immunotherapy of some sort, but like you've scratched the surface on all night. It's turning all the negative impacts of the stigma. We talked about, the reluctance to see a physician, which can lead to delayed treatment, which increases the mortality. It's this domino effect. And so what happens when we remove that stigma? The average American, sitting at home watching the lung cancer living room that knows nothing about lung cancer probably has no idea that lung cancer is the leading cause of cancer-related deaths. According to what we see every day on television and the stories we read, we think breast cancer for women, probably maybe prostate for men. And the reason is because, those cancers are so much, they're so much more united in that sense, and they're heavily researched. And now they have such superior survival rates. And what we know about tobacco, like everyone's talked about tonight, we know that tobacco is obviously a cause for lung cancer, but it's a cause for many other diseases. Yet when you go in for your routine checkup, you still do all of your early detection screenings. And so I think of it like the tripod. And I'm going to steal this from Chris Draft. You have, prevention, early detection, and treatment. And we have made these huge jumps in treatment in the last 10 years. Bonnie says it all the time. I can't remember how she says it, but something along the lines of there's been more drugs in the last 10 years than ever before in lung cancer, which is so amazing. But I think of it like Chris Draft. If you're moving the football down the field, you don't want to stop on the 30-yard line and kick a field goal. You want to keep going for the end zone. You want to keep pushing. And so I think the three-pronged attack, if we can start to eliminate the stigma, we can increase the prevention and increase the early detection.
I use the stigma as a dark cloud that hinders our access to all the great things in all the innovations, from how it's affecting individuals to participate in screening or to go get that symptom checked out, or for a doctor saying, yeah, let's run the biomarker panel to see what this gives us, to whether we decide to provide appropriate palliative care to someone because, do they really deserve, our best effort. And building on what Stephen, what you said, another of Chris Draft's ideas is that we can turn the corner on our lobbying and advocacy efforts to infuse more optimism and say, look at all the success that we've had. Can you imagine what we do if you doubled our funding, if you doubled the portfolio, if you tripled or quadrupled the portfolio of lung cancer research at various organizations? Imagine how much further we could get. And as we just disperse that cloud over everything, I think it's gonna provide sunlight and hope and optimism across the entire cancer control and care spectrum, and everybody is going to have more opportunities if we can do that successfully.
One of the things that Jamie just mentioned is the idea of funding research. And in our community, we have fought for every dollar that we get. We've fought for every dime that we get. I go on the Hill at least once a year, and what I find is that I have to argue against spending money on prevention because so many large organizations have spent the last 50 years saying that lung cancer is a preventable disease. Spend all your money on smoking cessation and anti-tobacco media. So they do. They spend a ton of money on prevention, and prevention isn't just tobacco cessation. If anything, prevention truly is tobacco elimination, but nobody's talking about that. But what we need is we need a moonshot. We need a real moonshot in lung cancer. And a moonshot might be $25 billion over the course of the next 10 years. But it's not $10 million or $20 million to the Lung Cancer Research Foundation out of the DOD. What we need is a sincere and large infusion of cash into lung cancer research if we want to eliminate it. And I think we can do that. We're on the path to doing that. And that's really and truly the most exciting thing that's happening right now, is that there's so much research that's happened in the last 5 to 7 years, and so many good outcomes as a result. Our survival rates have gone from a 5-year survival rate of 16% when I was diagnosed to up around 21% now. Our death rate is down this year, is down to an expected 135,000, which sounds really crappy, but by comparison to past years, it's really, really good. Mm-hmm. We need to get it down to about 10,000. And I think we're not that far from doing it, but we need the support and the research funding to do it.
If you were to ask one thing of our community to help in this effort to decrease and eventually eliminate stigma, what would the ask to our community be?
Eliminate the term smoker or non-smoker. Just get that out of your lexicon. A good friend of mine told me once that I should tell people that I used to raise birds, because I did. I raised parrots, or I had parrots. And when you have parrots, they have dander, and dander has the same effect, some people will say, as does asbestos. So give them something else. I raised parrots, or I lived in a dirty city, or I lived in Steubenville, Ohio, and got dust from Weirton Steel every morning.
I would just say uniting the message as a community. We take so much pride in empathizing with each other and supporting each other, but I do think sometimes we get we get a little bit segregated in the sense where we go, oh, well, I have this mutation, or I have this mutation, or I have small cell, or I have non-small cell. And, I think one of the big reasons why some of the other cancers have gotten so much traction in regards to the fast tracking of the research is because of the united message. So unity, I think, is probably my words of wisdom.
How can we prepare to deal with stigma when we see it, when we face it, when we experience it ourselves, and have a plan or have a way that you feel comfortable. There is no one right way to confront stigma when it's dealt to you. It's the right way is your way in terms of do you prefer to give them another reason? Do you prefer to ask them why they would ask you that? Do you prefer to tell them that actually using smoking cigarettes is not the only thing? So what is the most appropriate way for you? And actually GoTo has a pamphlet that outlines some of those strategies. But the last thing, and I know you asked for one, and I'm failing miserably at that. But the last thing is to invite folks to engage the Lung Cancer Roundtable, which is a stakeholder group that GoTo is very actively involved in, and working toward this National Stigma Initiative to learn what's going to happen with that initiative as we gather resources to launch some of the strategies that we've been developing that have been very well supported and guided by our advocates. And there's lots of really good ideas and opportunities that are going to come out of that for us to really change the face of lung cancer and help our society think about our community differently, embrace us more effectively, and I think everyone can come out a winner of that effort if we can really rally around it. So.
That's great. I appreciate all of you and all of your input. This has been a stimulating and thought-provoking conversation. I know for me, and this isn't the first time we've had it, but I learned something new from each of you, as well as many others every time we do talk about it. And with that, we'll say goodnight to everyone, and we'll see you next month.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I'll be brave if you're brave. I'll be brave, but only if you're